Hi there, it's Dr. Neurosurgery Greenberg, and today we are talking about acromegaly, and this is from the pituitary adenoma series. So for suspected acromegaly, the most useful test is an IGF-1 level, the somatomedine level. This is because it is an excellent integrative marker of the average growth hormone secretion. Normal levels actually depend on age, peaking during the puberty. It depends on the gender, the pubertal stage, and also the lab. Typical fasting levels are different. And these are, you don't have to remember these. You just need to know that growth hormone is a very capricious, it's a very tricky serum marker. And if you are relying on the growth hormone, then you will be in a mess. The normal basal fasting level is less than 5 nanograms per ml of growth hormone. But in patients with acromegaly, growth hormone is usually more than 10 nanograms per ml. But as I said, it can be normal. Okay. The normal basal levels do not reliably distinguish normal patient from growth hormone deficiency. And then due to pulsatile secretion of growth hormone, normal patients may have sporadic peaks up to 50 nanograms per ml. And sometimes acromegaly may be present even with growth hormone levels as low as 37 picograms per ml. Pico is 1,000 times smaller than nano. So you cannot define acromegaly on the basis of growth hormone alone. You can get a rough idea, but it is not a reliable indicator at all. But what you can use this growth hormone level for is that it can indicate a double mortality rate and double the colon cancer risk in case of increased growth hormone levels. So that is the takeaway. Now coming to other tests, there is the oral glucose suppression test, which is less precise, more expensive than measuring the IGF-1, but it may be more useful than IGF-1 for monitoring initial response to therapy. Okay, so OGST you will do in the initial therapy stage. Growth hormone levels are measured at 0, 30, 60, 90, 120 minutes after giving 75 grams of oral glucose load. If the growth hormone nadir, which is the baseline, is not less than 1 nanogram per ml, then the patient is acromegalic. But it is contraindicated in patients with diabetes and high glucose levels, and growth hormone suppression may also be absent with liver disease, uncontrolled diabetes, and renal failure. Then growth hormone releasing hormone levels can also be measured, and they help to diagnose ectopic growth hormone secretion in a patient with proven acromegaly, and you cannot have any evidence of pituitary tumor on imaging, you don't see it. Then you look for ectopic growth hormone secretion, and in that case you will go for growth hormone releasing hormone. So if a patient has an extra pituitary source, then you look for a chest and abdominal CT MRI to look for the tumor that is secreting it. Then there is a GHRH stimulation test. The results may be discordant in up to 50% patients, and this is rarely used because growth hormone releasing hormone stimulation is not a reliable test. Then there is octreotide scanning. You use SPECT imaging 4 and 24 hours after injection with 6.5 microcurie of indium-111 octreoscan, which is a somatostatin receptor imaging agent. So you basically image, and wherever the uptake is more, that means that is the producing tumor. Now coming to the last topic, which is radiographic evaluation, how you evaluate or image the pituitary adenoma. So Basically, MRI with and without contrast is with dedicated images throughout the pituitary, which are spaced 1 to 2 millimeter apart, is the imaging modality of choice. Thin cut CT through the sella or sphenoid region or CT angiography may also be used to augment the MRI, or they can be used in place of MRI when it is contraindicated. Then there are 3 Tesla MRI scanners which may produce finer anatomic resolution relative to 1.5 Tesla scanner, but in Pakistan we usually have at max 1.5 Tesla, and it is very expensive. So coming back to our topic, 50% of pituitary tumors which are causing Cushing syndrome are too small to be imaged on CT or MRI at the time of initial presentation. So you have to do endocrinologic testing to prove that the pituitary is the origin of the tumor, origin of the endocrine disturbance. The normal AP diameter of the pituitary gland in females of childbearing age, that is to say 13 to 35-year-old female, is less than 11 mm. For all others, the normal is less than equal to 9 mm. So the normal is 9 mm for everyone except women of reproductive age, which is less than equal to 11 mm. And this is the AP diameter. Pituitary glands in adolescent girls may be physiologically enlarged and due to the hormonal stimulation. Okay. So MRI, as we said, is the imaging choice for pituitary tumors, and you have to write that it is a pituitary protocol. It is especially helpful when looking for a microadenoma. For follow-up of macroadenomas, you do routine coronal and sagittal pituitary MRI with and without contrast with detailed coronal cuts through the pituitary. And sometimes you can need dynamic images, but if you are confused whether it is the tumor or the pituitary, then you have to do the dynamic. So what are your findings? MRI provides basic information about invasion of the cavernous sinus, about location of the carotids, whether they are involved or not. Okay, but the MRI may not be able to show. And then another thing that you need to know is that sometimes the tumor grows superiorly through the diaphragma sella, and supracellular invasion leads to elevation of the optic chiasm, and it can invade the cavernous sinuses, and in this case the flow voids within the cavernous segment of the internal carotid arteries, if they are not, whether they are involved or not, can also be recognized by the flow voids. So the adenoma will not take up the contrast. The contrast will be taken up by the pituitary gland itself. So if you look at the MRI, I will show you a picture. In this picture, the OC is the optic chiasm. Then you see the pituitary stalk. Then the pituitary itself has taken the contrast, and the tumor has not taken the contrast. It is hypointense, and the carotids can be seen on either side in 75% of the T1, and it will be high signal hyperintense on T2, but 1/4 may behave in any other way. Okay, and enhancement is very time dependent. So imaging must be done within 5 minutes of contrast administration to see a discrete microadenoma. So you have to be very quick. Within 5 minutes of administering the contrast, you have to image the pituitary in order to see it. Initially, gadolinium enhances the normal pituitary as there is no blood-brain barrier, but not the pituitary tumor. But after 30 minutes, the tumor enhances the same way. And then dynamic MRI scans can be used to increase the sensitivity, and the contrast is injected while the MRI scanner is running. That is how it is dynamic. Then neurohypophysis is normally a high signal on T1 weighted. So the posterior pituitary takes up a high signal on T1 weighted image. You have not given contrast yet, and it will be hyperintense. Why? Because of phospholipids. Absence of this bright spot often correlates with diabetes insipidus, as this may occur with autoimmune hypophysitis. But failure to image the bright spot is not uniformly abnormal. Sometimes it can be a normal variant. And then deviation of the pituitary stalk, if you see that, then it may also indicate the presence of a microadenoma. Normal thickness of the pituitary stalk is approximately equal to the basal artery diameter. So this is what you have to remember. So that is all for today's video, and I will see you in the next presentation. Thank you.